All right. Hello, everyone, and thanks for joining Avoiding Interoperability Pitfalls, a smarter path for USCDI version 3 and version 4 readiness. My name is Jordan Leibovitz, and I'm part of the marketing team here at IMO Health. Before we get started, a few housekeeping items for you. First off, this is being fully recorded and will be available to you after the webinar. If you have any questions throughout the session, put them into the questions section on the Zoom webinar console. Once our speakers wrap up, we'll do some quick Q&A. Today, we have my lovely colleagues from IMO Health, our product manager, Carrie Karsten, who will be moderating our session, along with Misty LaFave. She is the Director of Product Management at PointClickCare, and Andre Demirad. He is our VP of Corporate Strategy at IMO Health. So without further ado, I'm going to pass it on over to Carrie.
Thank you so much, Jory. And thank you all for joining us here today. We're going to have an exciting discussion around USCDI and, avoiding interoperability pitfalls. But before we really jump into the conversation, I'm just going to briefly kick some things off with an explanation of what is USCDI overall. So USCDI, it's the United States Core Data for Interoperability. Essentially, it's a curated or standardized set of healthcare data classes and data elements that facilitate health information exchange across different systems nationwide. So think about the things within your EHR, like the ability to categorize your patient data by demographics, but more specifically, either like their ethnicity or preferred language, or more clinically relevant information like medications, but being able to identify those dose or route of administration. So some examples here when we say data classes, like your demographics or your medications are those higher level classes where within those they have elements. So that would be like your ethnicity or the dose or route of administration. And so USCDI acts as a common language for healthcare systems. And if we think about things like fire, it definitely leverages the USCDI standards. So it helps ensure that data, whether it's, patient's ethnicity, medication dose, it can be easily understood and used consistently regardless of the originating system. And so this standardization, it helps improve the communication across systems, helps reduce errors, and ultimately enhances patient care. So where did we start here? So ONC, which is now known as ASTP, or ONC, which is the Assistant Secretary for Technology Policy and the Office of the National Coordinator for Health. They are making USCDI v3 a mandatory standard for all certified EHRs and health IT systems starting January 1st, 2026, which is right around the corner. And right now, the current compliance version is v1. So throughout the webinar, we're going to talk about the differences between v1 and v3 and the impact that those differences really have on organizations. And what does USCDI non-compliance look like? Well, a few things which we'll kind of touch on again throughout this webinar. Reputational risk, or your reputation could be at risk. There could be risk for information blocking fines, delayed CMS payment, and most importantly, a negative impact to providing efficient and effective patient care. So with that kind of little high level of what is USCDI, I'm actually going to pass things over to Andre. So Andre, can you help introduce who is IMO Health and why are we uniquely positioned to help solve USCDI problems for our customers?
Yeah, thanks, Carrie. So IMO Health, we are a clinical data enablement company focusing on empowering healthcare solutions, meeting any kind of data challenge that might be seen into the marketplace. As a company, IMO Health's been around for about 35 years, and our core business is using and enabling our vendor partners with the largest and most widely used managed terminology knowledge layer in the industry. So really what that means is if you walk into any healthcare institution in the United States, and as that doctor is typing data next to you, whether it's your patient's problem list or your problem list, or they're adding an immunization for you, the doc is effectively having like a Google-like search experience behind the scenes. for about 95% of the US healthcare market and the exponentially growing amount of institutions internationally, IMO is how that doc is actually typing that information in. Or in the advent of AI and ambient operations, how that grounding representation resolves to the clinician's voice as it gets written back into the system. And that's a big feat as you really think about it. And for the last 35 years, we've been that almost like Intel Inside in healthcare, empowering and maintaining these data operations for these institutions. And even in the past, even though USCDI is a more recent use case here, even in the days of meaningful use, IMO helped lift and shift organizations to meet their regulatory needs for the different versions of meaningful use that were back in the day. So as your regulatory requirements happened, where you had to have CPT codes on different immunization orders or RX norm codes on medication representation, organizations were really having a tough time keeping that mapping requirement up to date. And IMO was more than happy to step in and help support them, just like we are today with USCDI.
Awesome. Thanks so much, Andre. And Misty, thank you so much for joining us here today. I think your insight here is really impactful. So kicking it over to you a little bit, if you want to give us some background on who is PointClickCare and really why did you decide to partner with IMO Health to support USCDI compliance, and kind of more importantly, like, how did you get leadership buy-in that IMO was the right partner?
Awesome. Thank you. Well, thank you for having me, and excited to talk about this. Maybe not exciting for everybody, but definitely for me. So PointClickCare has been in the industry for over 25 years. We really started serving vulnerable populations in the post-acute and long-term care side of healthcare, and really focused on skilled nursing, senior living, and providers in that space with our EHR technologies. We've also expanded out across the care continuum around care transitions and care coordination. So as you can imagine, interoperability is very integral to what we provide to our customers on a day in and day out basis. And when we really started looking at we were being hit, like many of the industry, around regulatory needs and how we're going to comply with 21st Century Cures Act, as well as really, our customers were looking at us to help them solve their interoperability challenges, as well as complying with regulations. So we really saw this as an area where we could provide additional value to our customers, as well as our business, around having a highly interoperable platform. And that's really how we really thought of it, and really was able to get leadership buy-in, is really about taking that and providing that value back to our customers, really making it easy for them to have a very highly interoperable platform, while maintaining and getting that regulatory certification for our certified EHR that they could also utilize, and then complying with those regulations. Ultimately, it was about providing the value, self-service, and reducing any risk around information blocking, and providing that back to our customers, and as well as ensuring that we're setting ourselves up for the future. And as we kind of embarked on this, we knew that setting that standard up front would allow us to grow and advance in the future.
Thank you. You mentioned a lot about like the growth in the future, and one thing that we want to touch on really briefly here, I'm going to share a slide here. When we're talking about USCDI, I mentioned earlier that V1 is the current compliance. And so looking into where USCDI growth is going, we start here at V1, and it's kind of like the base level, the minimum requirements that any organization really needs to be compliant. And within that, V1 contains its 52 data elements across 16 data classes. V2, which if organizations kind of kept along, it's helpful, but a lot didn't because it wasn't necessarily a requirement here. But now that we're at V3, and that is a mandatory version that we begin to think around compliance, we've now increased the data elements to 94 and 3 additional data classes, making it a total of 19. So we've nearly doubled the amount of data classes and increased the data class, or doubled the data elements, increased the data classes that we need to be able to support. It's also not a one and done. So once we get to V3, it's just going to continue to grow. We're already looking at V4, which IMO is already in a state where we are supporting all of the content needed for V4, and we're tagging or flagging it in a way that is making it easily ingestible for all organizations. So as you have data incoming, or we need to kind of pull out that data from an EHR, we have those classifications around the code and the content, so we easily know how to categorize it. And then when we think about things like fire, it helps us easily facilitate where in those fire messages all of that data and that content goes, which is really huge. And fire is that standard, that communication, that standardized language that we're all using. And then if we think about growth and how do we support growth, well, V4, there's an additional 20 new data elements thus far and 1 new data class on top of those V3 standards. And so IMO is here, and we're staying ahead of the game with all of those required codes that need to be supported under USCDI, and we're maintaining that data ahead of time. So V4, it's January 1st, 2028, when that becomes potentially a mandatory requirement. But any organization can work with us now to kind of get ahead of that and start working towards that already. So we're not in this moment where we're feeling the pinch or the pressure of having to be compliant within, in this case, less than 6 months. January 1st will be here. But IMO is here to partner and help facilitate that venture, or that journey towards compliant. So again, just a couple of things, like if we're not compliant, what are the things that we're facing? Reputational risk, which is really a big one for organizations. Information blocking fines, which Misty, I know you kind of mentioned trying to avoid those. Delayed CMS payments, and then being a blocker to efficient and effective patient care. So now it's also important to note here that IMO Health alone, it's not going to make an organization 100% compliant or certified with USCDI needs. So all EHRs or health tech companies, they're going to have a little bit of a lift on their own to facilitate the compliance journey. So Misty, before PointClickCare started their journey with IMO Health, what are some of like the biggest pain points that you faced in kind of maintaining that standardized data for compliance with USCDI?
Yeah, I think one, we didn't have that deep clinical informaticist knowledge around code sets and mapping. And then as we started to kind of, I would say, peel back the layers of the onion, we realized that it was a huge undertaking. And, when you look at it from a regulatory perspective, and as you were sharing, there's timelines, and trying to meet timelines and take on the thought of mapping and utilizing those standardized code sets isn't something we felt like was time well spent for our teams, or the effort we wanted to put into it. And then we also had various vendors that we had worked with in the past of, for this little thing or that little thing, but we hadn't really looked at it on a larger scale. And so we really needed to step back and look at a larger scale of how we're going to approach the mapping and ensuring that we're utilizing the standardized values. But also we noticed that we had already been working with IMO and saw the effort and what they had done with us in the past, that we really felt like there could be some commonality in some areas where they could really help us. I'll also kind of just stepping back, right? We're talking about ICD-10, but we also knew interoperability was an area we needed to expand in, that we weren't, hadn't really put as much focus on it as we needed to. And so as we step back and look at that, we saw that we really needed to, have a broader interoperability perspective, be able to have the clinical mappings and the informaticist knowledge or someone to help us with that. And then also to ensure that we could help standardize across the board, because we had a very distributed customizations. We had immunizations that were customized, allergies that were customized, problems. And so we really had a lot of customizations we needed to tackle as well.
Yeah, Andre, from the sales perspective to Misty and PointClickCare's problems, it's not just them. I mean, this is a broad issue that we're seeing. And are there any other points that you would add to kind of some of those pain points that you're seeing?
Yeah. And I think the big market piece that I'm seeing, and this is market independent, whether you're an electronic medical record or your laboratory information system or your health information exchange, or even if you're a research organization needing to deal with genotypic and phenotypic representation as part of an interoperability feed. That's not regulatory yet. But if you're going to have some sort of standard-based communication to meet that need, you need to have an easy way that everybody agrees on how to send that information out. And it first starts with, how do you bucket data appropriately, and how are you maintaining that bucket of data in a standards-based way? And I think that realization is hitting the market independent of whatever kind of use case you're getting at. So a good example, you hear the word compliance coming up on today's webinar pretty often. And that kind of compliance department that might be at your organization might be saying like, hey, state of California just told us we need to have SNOMED codes on all of our LOINC or on all of our lab results. That's something new that we have, but we're noticing it's not coming out of my institution, or it's not coming out of my enterprise, or it's not present in my enterprise data warehouse, or it's not representative in my electronic medical record. Those kinds of requirements, are not necessarily just a state of California requirement. These are actually required as part of interoperability feeds for USCDI representation. So even though your compliance department or your technical team or your informatics org is saying like, hey, we just need to go do this, it actually starts with, hey, this 5-letter acronym of USCDI is setting up the tools and direction of which I need to go to as an institution needing to bidirectionally communicate on clinical data. We need to adhere to this representation, and this is the big problem to deal with. And even if I am a small, mom and pop doc shop, do I need to ask my electronic medical record, how are you guys helping me with USCDI compliance? Is it on my shoulders to massage my data to make sure that I'm adherent to it? Or are you doing it as a vendor for me, supplying that information and maintaining my data for myself? Those kinds of key questions are really important to make sure, like, how risk averse should I be in this kind of ecosystem? And I think a lot of organizations, especially moving into USCDI v3 compliance, again, needs to become regulatory come Jan 1 of 2026, are starting to move into that modality to send and receive that information, understand that information. But it's coming up real fast. I think this summer we've seen an almost, I hate to use the word tsunami here, but a tsunami of use cases coming in to say like, hey, I need to keep this content up to date, and I don't have that informatics chops. IMO, you guys are the best known secret that's in the industry. Can you guys help us out here for this use case? And we're more than happy to help.
Yeah, and knowing that time is of the essence, especially with January 1st being right around the corner. Misty, how do you think PointClickCare is now better positioned for even the upcoming, but also future regulatory changes? Because we all know they're coming.
Yeah, I think the biggest thing I see is really the time and effort, and it really helps accelerate us. So, we started with V1, and as you'd shared, there is a set of data elements and classes with that, and then we're just building upon that. But we really set kind of the inroads or the implementation paths with IMO early, so we are able to build upon that and take advantage of the work that we had already accomplished and continue to build and accelerate that. So it's not as big of a lift every time. And as you also shared, is that, these regulations are coming, and it seems like they're coming faster and more frequent. And so it's not always easy to say, oh, I need to go and shift my roadmap or all my plans to go accomplish these regulatory needs, and the time and effort and cost to that, so having a partner like IMO helps us accelerate that and also have the predictability, knowing where we're at and having that standardized data and the data to be able to utilize within our EMR.
Can you shed any light to maybe how, or maybe some specifics from like IMO, the things that you're utilizing to approach capturing, standardization of problems or allergy data elements as part of, your kind of not only the clinical workflow, but the behind the scenes, like how you're actually capturing that well, without giving away secrets, of course, but.
Yeah, no. So like, for example, on the allergy, we were able to integrate with allergies and terminologies there from IMO, and we're able to leverage their pick list. So instead of having to re-enter everything, we also have customers that like to have a lot of customizations. So by utilizing the allergies, one, we're standardizing on terms and the terminologies, but we're also standardizing on and integrating that directly into our EHR of pick lists. And then we're able to leverage that internally of being able to call that information back into, so Cures Act requires the creation of a CCDA. So then as we've incorporated the terminologies for allergies, then we integrate that into our API, and that becomes a core part of our clinical care document that then we can send to a hospital or an ER if that patient needs to transfer to another care setting. So, and then we're also with allergies, we've also got nutritional data. So we're providing support for our residents around their nutrition, so that allergy list not only gets integrated into our EHR, but we're also able to integrate it with our allergies component, or our nutrition plans and our meal plans to show, hey, they have an allergy to nuts. So we're able to use that integration in many ways and not have to rebuild it every time.
Andre, anything additional you'd want to add there about, strategies that help make data structured and shareable?
Yeah. I think Missy's hitting all the points that are just incredibly important, and I second them all. The areas that I've also kind of seen of where different kind of data strategies are occurring here. What we've been talking about has been kind of these back end data operations, right? I just need to make sure I have these codes in place. So like as an example from like a pick list, like, hey, does that pick list have a SNOMED code? Does that pick list have an RX norm code attached with it? Does that representation have that appropriateness of content needed for interoperability requirements? That's part of the story. Because as a product owner or as a data governor or data steward or as a enterprise data governance organization, not only do I have to do that kind of work, but if I'm going to make it usable to the clinician at the point of care, that's not lost as a usability operation, right? Because if all I'm just getting is just like, as an example for a visit diagnosis, is just an ICD-10 code, I might meet the regulatory needs and make sure that I have an ICD-10 code or a SNOMED code for a visit diagnosis. But if I don't have an easy way for the clinician to document that appropriately, so good example I like to use with presentations in many cases is if I have a patient with hyperphosphatemia, the closest ICD-10 code is other disorders of the phosphorus. Well, if I'm a clinician and I'm trying to look for a patient that has hyperphosphatemia, like technically I'm right with other disorders of the phosphorus ICD-10 code, but that's not what's going on with the patient. I need an easy way, not only to meet that regulatory need of documenting information, but also the clinical usability need so that I'm happy as an end user using the platform itself. That is something that's not lost on a lot of organizations trying to make use and differentiate their use of their software algorithms. We've helped support a lot of these organizations meet and exceed those needs to continue and keep that clinical satisfaction in their operations. And not only furthermore that, but so as we think about just regulatory compliance and usability here, but this is all happening at the same time that financial institutions are actually changing behind the scenes. So HCCs were changing between V24 to V28, and that was done like in between of all of this stuff that was going on behind the scenes. And then all of the code sets that we've already identified on today's call, CPT, HCPCS, LOINC, SNOMED US, all these different code sets. This is not just a updated twice a year type of thing. These domains, these representation of code sets in these data classes, they get updated anywhere between 60 to 80 times a year, depending upon which data class you're looking for, which use case you're trying to write back into a record. So like if you're not maintaining the ecosystem behind the scenes, you're going to be left behind. And that puts a big target right on the software applications themselves to say like, am I compliant? Am I doing it well for the clinicians? And am I doing it well so that I keep money in the pocket of my organization? If I'm not keeping that as a measurement of success, like those are behemoth operations to deal with at any given time. And that's why organizations like PCC and others have looked to IMO as being that foundational knowledge layer to help support them behind the scenes, because we enable that workflow for them in an easy to consumable way. So we're super excited to see that happiness occurs, like with Misty's engagements that we've had today with PCC, but also welcome the challenges that happen from a regulatory way, because just like with meaningful use back in the day, we were ready to help support any kind of software application meet and exceed that need.
I like that you emphasized the potential for growth, and then everything's like a partnership. And I know Misty, you as well have dropped partnership. This is not just IMO, it's not just PointClickCare, it's a partnership between us. So where do you see IMO Health really helping accelerate your priorities in the future? And like, how has this partnership really elevated your capabilities as an organization?
Yeah, thank you. So I would say we've really, as I mentioned, took a step back, and we're really taking a platform approach. And so when we look at IMO, they're really a huge technology enabler for us to accelerate our capabilities. And we look at things such as content management, terminologies, as well as normalization of data. And we're really thinking of how do we enrich the data and make it usable in other ways. As we've started to standardize it, it really opens the door to have those code sets for expanding healthcare operations use cases, expanding payment system use cases, expanding AI use cases. So it really has set the foundation for how we can leverage the standardized data, all the work we've been doing with USCDI, and build upon it. It's really, I would say, just the foundational enrichment of the data so that we can go do these more exciting things that we see in healthcare, and how data can move from one care setting to ensure that we've got a good care transition for an elderly person moving from one location to another, ensuring their medications, their allergies, their immunizations are all standardized and codified so that no matter who's receiving that can make it useful. But then how do we go build upon that, right? So that's really what I'm excited about. And I think when it comes to our partnership with IMO, I feel like we have a very open and transparent partnership about helping share with IMO where we're going and what are the things we want to go do, but also they come to the table and say, how can we support you? I'll just tell a little kind of tangent is, in the current version of USCDI, we had some areas where we needed to better improve how we were working on labs and RADs codes and how we codified that. That's not something we do. We work with other third-party vendors. And so how do we work with IMO and our third-party vendors and come together as a solution? It wasn't something just for USCDI, but it was something that we needed internally on how do we go improve our system and make it more extensible and usable beyond USCDI. And that was a great part of our partnership.
Yeah, nice little plug for our core procedure product, which, by the way, I think we do have a webinar coming up for that in the next coming weeks as well. So if anyone's curious, but Andre, anything that you want to add on top of that?
Yeah, I think you're thinking about these all right. Like, even though, if you were to take a step back and put yourself in the shoes of any software application that might be out there, whether I'm dealing with ambient documentation or if I'm dealing with ambient intelligence. These are all the big buzzwords that are happening in the marketplace. Now, as those data operations are trying to understand longitudinal data, as they're trying to understand the data operations to make attuned ambient workflows for the clinician or whatever kind of use case you're dealing with, it all starts with needing to have good data. And if that data is not kept up to date, is not maintained appropriately, is not represented in a comprehensive way, Missy used a great lexicon here, extensibility. If you're not meeting the needs of that use case that you're trying to build with some AI operation behind the scenes, you're going to have the colloquialisms of bad data in and bad data out. And we're seeing this with hallucinations across the industry. Great use case that I had heard from Dr. John Halamka, who's the CTO over at Mayo Clinic platform, or I'm sorry, president over at Mayo Clinic platform. He was saying, it was like, hey, I was trying to tell an LLM based upon my data. It was like, hey, I'm trying to do this surgery, and can I also do this other surgery at the exact same time? LLM, based upon the data that I'm dealing with and that I've used inside of my system, can you tell me whether or not this would be a successful procedure? And would it and show me the presentations that I might need to have to make the argument internally to see if this is going to be a good procedure? And the output did a great job saying, hey, this is exactly what you need to do, and this is exactly what the process would be required, and it would be a successful representation. But the more that he was clicking in on the system is that the LLM not only created a hallucination of it, but actually the bibliography that was being referenced was completely incorrect as well too. It was all made up behind the scenes. And I think this is the story that we're seeing right now in AI, in the realm of AI enablement behind the scenes. If you're not grounding your data in the truth of the clinician's voice and maintaining that over time, you will continue to have bad data in and bad data out. And this is the services operation that IMO enables for all of these different use cases behind the scenes, whether you are an EMR like PCC or whether you're trying to get onto the bleeding edge or the forefront of ambient intelligence operations. If you're not longitudinally grounding your data using the clinician's voice, you're dumbing it down, if you will, to code sets. And docs don't speak code. So if you're trying to make a use case here where you're trying to enable the clinician to be more active with things like AI, you need to be grounded in the way that enables the clinician with their own data over time, because those code sets change. So if you're grounding it on codes alone, you've missed the mark on accuracy, relevancy, and appropriateness. And this is where IMO has actually helped come in to enable companies like PCC, focus on the forefront to keep their businesses differentiated, because we've taken on the real hard stuff behind the scenes to keep that data maintained and up to date. So as I, maybe last point on this one is like, as we see all these different data operations occurring, as we see all these buzzwords occurring in the industry, it's super interesting seeing them start coming back to IMO to say like, oh, we've tried it ourselves, but we actually realized we needed to have that enabled clinician's voice behind the scenes to make it real. IMO help us find that path forward. And, because we've come across all these different use cases that are out there, more than happy to help wherever we can.
Yeah, I think that's the beauty of IMO, letting providers be provider, talk provider. Don't worry about the codes. IMO is here to help translate and then therefore empower the EHR and all of those downstream workflows with the quintessential standardized data points. Okay, just as a quick reminder to everyone, we do have a Q&A section out there. So if you do have any questions related to the conversation, feel free to put your questions out there and we'll do our best to answer. I do have a few that have come in, Misty. And most of them seem to be targeted towards you, but Andre, also feel free to add some color and insight as we go through. But one of the first questions, considering January 1st is right around the corner, how long did it take you or PCC as a whole to ensure your systems meet USCDI compliance requirements?
Yeah, I like to say USCDI is not a destination, it's a journey. And really, we started the journey 3+ years ago with Cures Act and USCDI V1. and laying the foundation. I will say the early part of that did take a considerable amount of work of just prep and getting ready for that. And I would say our IMO partnership kind of came in the middle of that. So we had a good year, and that it wasn't all dedicated towards that, right? We kind of knew what our timeline was, and we had set ourselves on some milestones within that year. So it could be accelerated depending on, how much effort you put towards it. It is all about kind of a timeline and effort there. But in our current journey with USCDI V3, again, we're building upon that, and we had set our milestones out in a 12-month manner, and it could be accelerated again depending on the effort that you put towards it. But that's how we've laid it out, is really around kind of spreading it out around the 12 months. I would say development time has really been probably a good 2 to 3 months of that. But obviously there's been some preparation, and then we do a lot of testing afterwards, ensuring that everything's aligned. And there's also, certification testing that goes into that as well.
Yeah.
I'd also say too, we've seen the same thing with a lot of other vendors. I think, Misty, the way that you've been thinking about this is incredibly smart, because not only at the same time, just getting back to what we were talking about earlier, that you not only had to make sure you had the buckets, but that you maintain the buckets inside of it, and then you had to test it, and then you had to make sure that clinical usability was there, and then you had to do regulatory reporting for it. It takes time and effort. So even though you're doing the hard work for 3 months, 6 months, there's still a tail to make sure that you're validated for that whole process. In the meantime, those code sets change. So it's not necessarily like, hey, it's a one and done thing. It's a maintenance burden over time. So I for those that are on the line here too, if you haven't gone through the methodology here, Misty's roadmap is spot on. Like what we've seen in the industry of being very successful, like you have to give it time. And even though these regulatory burdens say like, hey, it's Jan 1, 2026, the next one, V4, is Jan 1, 2028. So that means you effectively have like all of 2026 to get your ducks in a row to make it work for V4. But if you're not already developing towards V4, you're going to be left behind, because there's a lot of other things that are happening behind the scenes to keep up to date, and you got to be aware of it all.
Exactly.
All right, another question that we have in the Q&A, is it possible to summarize the most impactful differences coming in V3 of USCDI from the point of view of providers? So what are the main challenges that helps address?
Yeah, a few areas that I've seen that have been more focused. So payment, kind of including that healthcare operations and the payer side. There's more standardization and codification there. There's more around, the standard calls it health assessments, but it's more in the SDOH space of social determinants of health. A lot more data elements in that space. And really, I think it's, V1 set the floor, but V3 is really kind of trying to bring in more of the whole person. And we're seeing more things around nutrition as well, included in that. So it's really, I think, providing more of the ancillary pieces that don't necessarily, are around their medication or their immunizations, but more around understanding more about the person.
All right. Next question. Misty, with your customers and your partners, just even outside of IMO, have they mentioned anything to you about USCDI? Are they concerned at all?
It's different. I think it's depending on the audience and how you talk about it, right? USCDI, I think, is a very kind of, I would call it more of a technical term, right? It's in policies, it's in regulations. But when I talk to my customers, or my customers come to me, they're like, how do I meet my obligations for quality measures? How do I meet my obligations for this report back to the federal government, things, or CDC requirements? So we see it more about what is that they have to accomplish from a reporting or regulatory perspective with state and federal government. but USCDI and the interoperability capabilities that we provide with the USCDI data elements, such as the Fire APIs, which we have customers building applications on, or they're using a third party that built an application on our Fire platform and they want to integrate it in. Those are the type of conversations we have, is more of at the point of care or at the point of use within the system. And a lot of what we're building around USCDI and others are the enablers.
And another thing, we have another related question that's coming on something you kind of touched on your prior response. SDOH. Do you see SDOH data improving care coordination, or does it feel mostly like a compliance checkbox today? I mean, I know SDOH kind of has been evolving over time, and it still is evolving. So what are your thoughts on that?
Yeah, I think it depends on probably who you talk to and their care area. I think when I look from a provider lens and looking at SDOH and providers I have spoken with, is it's about, they need to understand, if they're going to be releasing them from a skilled nursing home, do they have access to food? Or if I'm treating them and they're coming into an ED and they were in an occupation where they had, high areas of lead or something that was influential to their health, and capturing that occupation or capturing whether, they have access to transportation, capturing those things help a physician and the providers I've talked to better provide care, because they are understanding the whole person and not just their specific problem that they're there for, or what the specific test results. I would call it more, it's qualitative data as opposed to the quantitative data that they're using.
Yeah, and I think I've in this, I don't know if you've seen this too in the industry, but SDOH assessments, even though the government has tried to standardize, hey, you need to ask this questionnaire with these questions and have like these kind of standard answers. I think what at least I've seen, I don't know if you're seeing this, Misty, is that representation of data is also the Wild West. How you ask of it, how do you represent it behind the scenes? How do you get an answer for it? How do you take that answer and interpret it to something that could be billable? So to make that last statement real for the folks that are on the line here, if I'm trying to track income inequality as an example, like how risky am me as a patient because of a possibility of an income inequality requirement here, if I make, let's say, $10,000 a year, but Carrie makes $500,000 a year. Interesting enough, it's the same SNOMED code as an interpretation of that kind of input, but only one of those answers is something that could be a Z-codable concept. And that representation is important, the way that you ask it, but how you get to the variations of the answer can take a lot of different representations behind the scenes. And that is unique to each software platform that's out there. And with USCDI v4 as an example, dealing with more behavioral health and trying to understand marginalized and underserved communities, or how do I deal with treatment intervention or care experience operations, like or even to the gold standard of medication adherence, like did I actually take the med? That operation is important to track during these processes, and it's only increasing in complexity over time. And even though we're trying to coach vendors on how best to ask the question, it's still going to be on the shoulders of the clinicians to pull that information out of them, either through an ambient process or through a structured documentation process. But it'll continue to be the Wild West in how you get there. But I think the consistency as both an electronic medical record vendor as well as a content vendor like IMO, it's how do I resolve that answer to something that can be actionable as well as analyzable? Because if I can't make it analyzable, then why even do the work? And that analyzable is going to be important to better understanding your numerator and denominator of patient populations, irrespective of where they sit. So it is going to be an interesting path forward, trying to find standardized ways of representing this information when there is, general standard, but not a true, like, you need to ask this question this exact way and get that exact answer the way that you need to. Like that does not happen in real life. So from a clinician's perspective, I foresee the Wild West continuing into the future, but It's up to us as software vendors to help enable that practice to make it more actionable and analyzable for you.
Thank you, Andre. All right, so I'm not seeing any more questions in the Q&A right now, but if something pops up, always feel free to continue reaching out. So I have one last question, Misty, for you before we kind of wrap things up here. And that is, what advice would you give an organization just starting their USCDI, whether it's V3, V4, readiness journey, and that maybe have limited resources?
Yeah, I think partnership has been really key for us, especially around trying to accelerate that. Making sure that your organization understands the benefits of USCDI. I think a lot of times it's thought of as, oh, I've just got to go do this to check a box and to fulfill my obligation around regulation. But I think if you can tell that story around improving interoperability and how it fits within your space, the value it brings to your customers, a lot of what we've talked about, they're foundational pieces, and USCDI is a foundational piece. But if we can get this right around the standardization, it can really start to accelerate an organization, not only around sharing data for interoperability, but also around creating models and using that data for other purposes as it's become standardized and codified. So I think it really helps unlock doors, and really helping have a partner there, as well as getting buy-in with your organization on where it can go is super helpful.
Thank you so much.
I'd also say too is like, even though the EMR is one area, the receivers of EMR data and those secondary data use cases, I think it also behooves everybody that's on the line here, or anybody consuming that data behind the scenes, to really take Misty's comment here to heart, because that is important. Because if we break down the telephone game as folks are trying to use that information, as it gets passed downstream, if we're not doing as much as we can to bring that clinician's voice to the data that I'm using, and all I'm doing is just barneying it down to something less specific to meet my specific business needs, I am creating the telephone game as it goes downstream. So I think for all vendors and all use cases that are on the line here, if I don't have a good content strategy to make and meet and exceed the standards, but make it usable as it goes downstream too, we're going to lose a lot of fidelity in data. And getting back to the AI comment we were making earlier, it'll continue with bad data in and bad data out, and that's not going to help anybody. And this data is us, everybody, right? I'm a patient. I'm also a consumer. So if I don't have a good way to represent this appropriately over time, I'm lost as a patient for my efficacy of data. And if I'm trying to own my own healthcare as a patient, or I'm trying to be the steward of that for any one of my family members, I want to make sure that it's the best thing that's there. Because if it's not, then I'm lost as a patient, and that's not going to help anybody. So we have a responsibility in the point of care space, but we also have a responsibility in these secondary data use cases to make the data the best. And if I were to say anything anymore on top of that, it's just try the most to increase the specificity of that data wherever possible, even if it's not required. That extensibility, like Misty was talking about, is so important to efficacy for analysis downstream.
Yeah, I do want to just add one thing I forgot to mention. There's a ton of material on USCDI online. The ONC ASTP has made great resources available. There's also like comments of how other people have interpreted. There are in some of the bigger regulations, there is interpretation. And so it's always been good to kind of refer that. And I will say IMO has also been a great partner in helping us of like, hey, is this how we would implement this, or is this how you would understand this data element, and how we should provide it? And so they've been also a great guidance for us in how we've approached USCDI and dug in. So I appreciate that as well.
Well, it's been a fantastic partnership, and we look forward to the future. As we know, compliance and regulatory needs are going to grow. So being able to grow together in this journey, I think, has been so beneficial for both sides.
Definitely.
Awesome. Thank you.
Yeah, thank you all. Jory, handing it back over to you for some final wrap up.
All right. So thank you, Misty. Thank you, Andre. Thank you, Carrie, for moderating. We're going to go ahead and close out. We hope you found everything useful in today's presentation. If you have any questions regarding IMO Health or any of our solutions, contact sales@imohealth.com. Thank you so much for attending. I know there's a lot of other ways you can spend your time, so we appreciate you. Thank you. All right. Goodbye.
Thank you.